Good afternoon. At the outset, I would like to thank the organizers for having given me opportunity to be before this elite audience. Today, I would be talking about 2D analysis and Doppler echocardiography in mitral stenosis. It will be a 15-minute talk. I'll be talking about 2D features of mitral stenosis, the Doppler evaluation of mitral stenosis, the associated feature, what's new, and how I usually go about it. Coming to the 2D features of rheumatic mitral stenosis. There is leaflet thickening, and characteristic of the leaflet thickening is it starts at the leaflet tips and moves on to the base. There is also reduced leaflet mobility, especially of the posterior mitral leaflet, and the anterior mitral leaflet takes the characteristic doming shape. This occurs because the tip of the leaflet is restricted while the body of the leaflet is free to move, giving it the characteristic hockey stick appearance at end diastole. You also have commissural fusion. This is best viewed in the transgastric basal short axis. Here you see a commissure, the anterolateral commissure which is fused and the posteromedial commissure which is free. It's quite difficult to look at this commissural fusion in a 2D. It's more easier to look at commissural fusion in a 3D. This is a 3D zoom which is cropped from the left ventricular side, and you can see that the anterolateral commissure is fused while the posteromedial commissure is free. And this commissural fusion gives it the characteristic fish mouth appearance in rheumatic mitral stenosis. You also have thickened and shortened chordae and also hypertrophied papillary muscles. Coming to the 2D echo features of calcific mitral stenosis. Now we will have to differentiate calcific mitral stenosis from rheumatic mitral stenosis. In calcific mitral stenosis, there is less commissural fusion and the smallest mitral valve area is at the base. This gives the mitral valve orifice a tubular shape, and the calcification extends from the annulus to the base as opposed to from the leaflet to the tip base in rheumatic mitral stenosis. Now this is a picture of calcific mitral stenosis. You can see a lot of calcium on the leaflet tips, giving it a characteristic 2D appearance. This is a 3D picture, it's a 3D zoom from the left atrial perspective. You're looking at a calcific mitral valve and the arrows are showing a heavily calcified mitral annulus, mitral annular calcification. Now coming to the Doppler evaluation of mitral stenosis. The first one is transmitral pressure gradient. Now you'll have to get a continuous wave Doppler across the mitral valve leaflet tips in one of the mid-esophageal views, and on tracing this continuous wave Doppler you would get the max gradient and the mean gradient. We usually use the mean gradient to classify mitral stenosis. The peak gradient is not used to classify mitral stenosis as it is influenced by atrial compliance and left ventricular diastolic function. We can grade mitral stenosis based on the pressure gradient, and any gradient greater than 10 millimeters of mercury is severe mitral stenosis. Now there are certain fallacies in using pressure gradient for classification of mitral stenosis. There can be underestimation of mitral stenosis if there's a non-linear sampling beam, there's a type 1 diastolic dysfunction or a low cardiac output. And there's an overestimation of mitral stenosis during tachycardia, type 3 diastolic dysfunction, elevated cardiac output and mitral regurgitation. The second modality is mitral valve area by planimetry. This is the gold standard and reference method for mitral valve area calculation, and biplane imaging is preferred in 2D planimetry. The crux here is the plane should pass through the tip of the leaflets and not the base of the leaflets in rheumatic mitral stenosis to calculate accurately the mitral valve orifice. Now 2D planimetry measures anatomical mitral valve area, while functional mitral valve area is calculated by PISA, pressure half time and 3D planimetry. The advantages of using planimetry is it is less dependent on flow conditions, chamber compliance and associated valve lesions. The disadvantage is it is not accurate in severely distorted valves.